All right, so first I'm going to start off by thanking folks. Essentially, the study that I'll be talking with you today about some of our findings has had multiple funders. So first and foremost, the National Institute of Mental Health gave us our first grant to start to develop this adaptation of multisystemic therapy for emerging adults. And then we had further funding from the National Institute on Disability and Rehabilitation Research and the Substance Abuse and Mental Health Services Administration. So we've had a couple of grants to support the work that we're going to be summarizing for you today. We've had a number of collaborators, because anytime you actually, excuse me, as you know, offer an intervention in a community setting, you need to have those important stakeholders who collaborate with you to get that done there. And ours have been Sarah Laurie and Ann McIntyre-Loner at the Connecticut Department of Children and Families. And we've had other research colleagues that have been wonderful supports and consultants for us. Chuck Lids, who's sitting over there, Ed Mulvey, Mary Evans, and Scott Hengler. And then we've had our team that has offered this intervention was offered by the North American Family Institutes in Connecticut, and they have been marvelous to work with. And lastly, and certainly not least, the emerging adults who have been participants in this study. We just have been so appreciative of their willingness to participate in research. One can always seek services in same meta research, and we've been very lucky that they haven't done that. All right, so I want to start off by talking a little bit about why we wanted to develop an intervention for transition age youth, emerging adults, young adults. However, I'm going to use that term loosely for any of the individuals in the age group that we've worked with, are primarily 17 to 21 for this particular adaptation. First and foremost, we were interested in developing something for them because we had data. This was from a statewide cohort of adolescent mental health system users, fairly intensive mental health service use, that showed us that if you look at their arrest rates for females here and for males there, that there's a fairly high annual arrest rate by age. For girls, there's not really a peak. It just is kind of chronically high at around 10%, which for girls is actually remarkably high. And for boys, it peaked at age 18 and was starting to come down, but still was not down to 13-year-old rates by this point. Now, these are fairly high arrest rates and risk, so risk of arrest was fairly high, but we were really looking at who might be a particularly high risk population that we could target. And depending on the intervention, if you're going to do something substantial, you often want a higher risk group. And what we were able to identify was that for males who had been arrested the previous year, their re-arrest rate essentially was around 50%. And for females, it hovered between 30 and 40%. Now that is a very high arrest risk in the population. And as we know, essentially, arrests have all kinds of negative implications for you in your future, depending on the nature of the charge, whether you spend time, these kinds of things when you get asked on a job application about whether you've ever been ever been charged, ever been found guilty, ever been convicted of a crime. People sometimes will answer that even if it's a juvenile offense positively, even if they don't have to, on those kinds of applications. You can be denied public housing, you can be denied loans for going to college, a wide variety of implications that come from having had an arrest record. And we also know that for mental health, for individuals who end up incarcerated, that's very challenging for their mental health conditions, that they tend to have worsening symptoms while incarcerated. So, it's very important to try to avoid arrest, and particularly during this important transition to adulthood, when young people are trying to launch their adult lives, move from schooling to working, to supporting themselves, to living on their own, to their adult relationships, that having had an arrest can be very deleterious to that trajectory into adulthood. So when we were thinking about what we should do to try to intervene, we were trying to figure out what factors, what are the kinds of things that you can target that can change, that you might target an intervention at in order to reduce getting, essentially, because of this target population has been arrested, to prevent a rearrest. And when you look at the literature, as is true for so much of the literature on transition age youth, there's literature for adolescents, there's literature for adults broadly speaking, 18 to 55. There's very little research specifically in this age group, although thankfully this is growing, and actually this conference gets to highlight a lot of the research in this age group. But at the time that we got the first grant, this was back in 2007, the research literature had a vast richness on some of the, what we would call the malleable factors in juveniles, that many of these had been the targets of juvenile interventions, reducing their contact with antisocial peers. These are factors that we know are associated with offending or resistance. So affiliating with antisocial peers, a lack of parental supervision and monitoring, having unstructured time during school and after school, substance use, having distorted cognitions and rational choices that didn't make for good decisions, and then being attached to school, prosocial peers, and family are factors that actually can help juveniles desist. When we look at the adult literature, we find that, not too surprising, peers aren't as much of an influence as we mature into adulthood. They're still very active during the youngest period of adulthood, but as we become older, we get connected into other kinds of networks. Our peers influence us less. This is true for offending in adults. Parental influence is lessened, and it's more indirect, but there are still influences of parents in adults and in young adults. Having unstructured time now, as a mature adult, primarily refers to being engaged in work. Substance use is still problematic for offending in adults. Rational choice and distorted cognition still play a role. And attachment now not just to prosocial peers, family, and school, but now really focus on attachment to work and attachment to spouse and family, your own family. So these are some of the factors that an intervention could target. And essentially for transition age youth, we were trying to develop an intervention that could sort of walk between what these look like for transition age. So when we're looking at antisocial peers, we still want to target that for the youngest transition age youth because they're still involved with their antisocial peers, but parental influence changes radically. As soon as a young person turns 18 and is a legal adult, even though they may be living at home, the nature of that relationship changes, and so that a lot of the evidence-based treatments for juveniles involve primarily working with the parent to help the parent change things in their child's environment. When you get to somebody who's 18 years old, and sometimes even 17, parents don't have that same kind of leverage. And so a big part of trying to figure out how to help reduce antisocial behavior and reduce recidivism in transition age youth with serious mental health conditions has to do with figuring out how to, in what ways to involve parental influence. And the flip of that is, how do you engage a young person on their own behalf for this age group? Now, what I had shown you about the factors that we know about juveniles and adults was from the general population. What we have less information on is for offenders with mental health conditions. And what we do know is that if you simply treat their mental health condition, interventions that have done that as a means to reduce offending behavior have been unsuccessful. So just reducing mental health symptoms does not seem to lead to reduction in offending or antisocial behavior. There have, excuse me, there is some encouraging evidence out of the wraparound approach that many people at this conference are familiar with, that they have had good outcomes in reducing antisocial behavior in with serious mental health conditions. But that hasn't been extended to young adults. Wraparound has primarily been used for children and adolescents up to age less than 18. And the approach that has looked at its effect on antisocial behavior was only used in adolescents. So we don't yet know what wraparound might do with the younger population. What we decided to do was to take a different evidence-based approach from the juvenile literature, which is multisystemic therapy, and try to adapt that for this age group who also has a serious mental health condition. And one of the things about multisystemic therapy, MST for short, is that in its standard offering, if a juvenile has a serious mental health condition, they can't use MST. That's an exclusionary category. If they have externalizing behavior, what's the word I'm looking For disruptive behavior disorders, yes, that's not a problem. But if there's anxiety, if there's psychotic illness, if there's PTSD, serious manifestation, if there's other anxiety or mood disorders, then essentially they will be treated by an MST team. So that had to be part of our figuring out what we were going to do with this model if we were going to use it. The other aspect about standard MST, and how many people in here are familiar with the MST approach? All right, I'm going to ask an embarrassing question. Who's not familiar? Because I don't want to bore people who don't really know it. A little less familiar. Anybody? Wow, everybody knows MST, isn't it? I have to tell you.
Everybody thinks they know, isn't it?
Yeah, I'll review it very quickly. But I have to tell you, the very first time I came to this conference, I was on my clinical internship here at Florida Mental Health, well, here, up the road at Florida Mental Health Institute. One of the faculty there said, if you go see anything at this conference, go see Scott Hengler present on MST. It's amazing. And maybe that had some influence on later asking to work with him on an adaptation of this. But truly, MST has had really remarkable impact. In the original study that he was reporting back in 1992 on, they follow these kids, those young people now I think are out up to 17 years, they still see a difference between the control and the treatment group. Really, it's quite remarkable. But let me go back to just very quickly on standard MST. It is an intensive home-based treatment. There's a team of 3 to 4 therapists. Each therapist has 4 to 6 families that they work with, and as I said, they primarily work with the parents or people who are acting as parents in a child's life. They promote behavioral change by empowering those caregivers and parents. They individualize the interventions for each family and youth. They target a comprehensive set of identified risk factors, and they're sort of known for looking at what they call ecologies, the individual ecology, the family ecology, the peer, school, and neighborhood ecologies. These interventions integrate, they're very rigorous about trying to use empirically based clinical techniques from the cognitive behavior therapies and behavior therapies. And the duration of full treatment for MST is 3 to 5 months. So for our adaptation for emerging adults, we wanted to make sure that the team addressed directly their antisocial behavior and their serious mental health conditions. We wanted to leverage and develop the emerging adults social network, which could include family members, but it could include others in their social network, because that's a very much an important part of the changing lives of emerging adults. We wanted to integrate a life coach and a psychiatrist for the emerging adults onto the MST team. So let me start with the psychiatrist. The psychiatrist, there's a version of MST for children who are presenting at an emergency psychiatric room. And for that model, they put a psychiatrist on the team. And we thought that was probably a pretty good idea for this, because we knew these were going to be young adults who could have crises, who may not have psychiatric care. We want to make sure that we have ready access. A life coach, which I think the second presentation in this is all about the life coach, but primarily a life coach was conceived of as somebody, since we might not have access with a parent to work with a young person in their natural environment, a coach was conceptualized as an individual who could be with the young people in their natural environment and encourage change and support them. And so we added coaches to the MST team. The interventions that the MST therapists delivered were mental health interventions, substance use, and trauma interventions. I'll show you some data. About 80 to 85% of the young people who were treated on the team had a co-occurring disorder for substance use. The team needed to target housing and independent living skills, career goals, relationship skills, and as needed, we had some young parents. They were teaching parenting curriculum. And you can see, if you think back about the malleable factors that we talked about, that there are a lot of these that relate to that, to being engaged in schooling or working so that you have positive engagement during the day. Housing and independent living has actually, homelessness has certainly been found as a factor that can contribute to offending behavior. Not so much in juveniles, but in adults. And the risk for this population, of course, is to prevent homelessness, to try to help them with developing that new skill of either living on their own or being able to remain in the family's home in a way that the family can sometimes tolerate or feel good about. So the structure of the MST for emerging adults, the MISTI team, is that there are 3 therapists, there's an on-site clinical supervisor, there's an off-site consultant, there's essentially a 1-day-a-week psychiatrist or psychiatric nurse practitioner, and then we have life coaches who are, they total 1.0 full-time equivalent, they're part-time people. And we tried to tailor that to, we've had some people that are more like 60%, or actually nobody's been 60%, but you might have some people with more or less time depending on what their schedules are. But most of these coaches have a job that they're doing elsewhere in their lives, and this is something that they're doing on the side, who are individuals who really enjoy working with this population and like to encourage people to do well. And a full team caseload is 12 clients. So each therapist carries 3 to 4 clients in their caseload. Any questions so far? Okay. Yes?
So this is completely plugged into South Carolina. We're doing the training there.
Yes. So my collaborators on this are the Medical University of South Carolina's. Scott has been a consultant to the project, and the major collaborator and clinical developer for this is Ashley Shido, who's not able to be here today. And one of her colleagues, Mike McCart, has come in to help on some of the trauma interventions because it's a major part of the therapy that's being done. So yeah, it's done with that in collaboration with that group. So our target population for developing this intervention was 17 to 20-year-olds with a diagnosed serious mental health condition. They all had an Axis 1 diagnosis. They've been recently arrested within the past 18 months or released from incarceration within the past 18 months, and they have to be living in a stable community residence. They can't be homeless, they can't be couch surfing. There has to be some place that they are living. And for those who come to the team right after having been incarcerated, there has to be a plan for them to have a community setting. Essentially, the focus of the team can't be that reintegration that is so critical, because that would really essentially shift the focus of what MST is there to do. So they have to have a stable community residence. Otherwise, this is pretty much the eligibility. And I'll tell you a little bit, I don't think we had a referral slide. Primarily, it was interesting when we first offered this. It was offered through the Department of Children and Families in Connecticut, which is a consolidated children's agency. It has child mental health, child welfare, and juvenile justice all under one office. And so we thought this was a great partner. They would probably all know the kids who had both involvement with the justice system as well as having mental health conditions. And what we found is when we went to talk to the referral sources who were in the justice system, well, they certainly knew about their justice system involvement, but they had a really hard time identifying whether there was a mental health condition. And when we talked to them in either the child welfare or the mental health side, they knew about their mental health for the most part, but they really didn't know their justice system involvement. So it was an interesting process of sort of sitting between systems and trying to elicit appropriate referrals. So we did a lot of educating about, essentially for the justice system folks, how to identify somebody who'd be a good candidate. We did the screening, but we didn't want them to send us everybody. We wanted them to start off with some sort of a screening on their end. And at the same time, we were working with the folks who are in child welfare and the mental health system for ways to concretely identify when young people have been arrested or have been released from incarceration recently. So all the challenges of doing real-world research were packaged up very nicely in this project. So let me tell you about the sample of young people that we worked with to develop this intervention. We ended up with a sample of 42 young people for this study that I'll be summarizing today. They were, not too surprisingly, most of them were male. There was a large portion that were African American. There was a small portion that were Hispanic. And for this intervention, because it was being offered in a state, they had a new law called Raise the Age. Several states have these, where they're increasing the ages that the juvenile justice system works with. They were raising the age to 19 So they were interested in, and they had no interventions that they had felt good about for 18-year-olds, but they also felt that they had to offer to 17-year-olds for it to be sort of fundable at their end. So we had 17 and 18-year-olds and a few 19 and 20-year-olds in this study. And the 17-year-olds technically could have accessed a standard MST team, except that they had a serious mental health condition. So one of the reasons that we ended up having 17-year-olds come to us was that they were good candidates for MST, except for the mental health condition. All right. Now, what I'm going to talk to you a little bit about is sort of our success with our research approach, as well as what we've been learning about developing the intervention. One of the things that is challenging with this age group is engaging them in research to begin with, and retaining them in research as you go along. As you might imagine, young people with a serious mental health condition who often have a substance use problem and have been involved in the juvenile justice or the criminal justice system aren't always the easiest people to track down. And they get cell phones, cheapo cell phones. And then when they run out of minutes, their cell phone number goes away. They get that cell phone number goes to somebody else. And you're trying to get in touch with them to set up your interview, and they don't have that cell phone number anymore, and they're not living at home, and they just broke up with their girlfriend, and you're trying to track them down. And we came up with lots and lots and lots of ways to track them over time. And I'm very proud of our research team, because we ended up having a 90% completion rate for our post-treatment interviews. Overall, we had a 91% interview completion rate throughout. So we've really had remarkable success, and part of that is just the strong approach that our interviewers take with engaging the young people in research and making that partnership with them about how important that is. And persistence. So we had 90% who completed a post-treatment interview. We had essentially 3 people out of those 41 who did not complete. 1 we could not find. Through all of our various mechanisms, couldn't locate them. 1 person formally said, I don't want to do the research anymore. And 2 people completed a last interview, but their treatment hadn't been completed. So let me tell you that this is data essentially from 2 phases of this research. In the first phase, we collected data for 12 months. In the second phase, we collected data until 4 months post-treatment. There's no comparison group in either one of these phases. It was primarily feasibility and development research. And in the first study, we didn't actually know how long treatment would go, but we thought 10 months was going to be the outset. Well, we had a couple of people who went for 12 months. And when we did their post-treatment interview, which was supposed to be post-treatment, they were actually still in treatment. So we've taken we don't have post-treatment data for that. Okay, so treatment retention, which is a very related topic then, we found that 51% of the clients, what we would call, with a very high bar, completed their treatment, which is that they had met all of the goals that had been set. Goals are set in partnership with the young person. There's no goal that a young person doesn't agree to that they work with their therapist. And that they were mutually agreed to be thought of as sustainable over time when we ended treatment. So if the young person and their therapist and anybody else who was involved with the treatment were all in agreement that we made this change and it's likely to sustain over time. So it's a pretty high bar. So 51% completed it. Another 15% ended by mutual agreement, which was that they didn't meet all of their goals, and they weren't all necessarily sustainable, but everybody was in agreement that further progress was unlikely to occur, and so it was time for them to move on to other things. Now we lost engagement, that piece that you really hate to do, with 20%, where over time they refused to come to the door when the therapist would show up. They wouldn't answer their texts, they wouldn't answer their phones. They basically were, through lack of being responsive, ending their treatment. And then we had 12% who ended up in a restrictive placement that was going to be long enough that we couldn't continue our treatment with them. And then 1 individual moved away. All right, where have I put my little gizmo here? All right, so looking at our outcomes, the first and foremost outcome that we're really trying to target for this group is to reduce arrests. And within those arrests, hopefully that they're for fewer charges or less serious charges. And we are still actually collecting data on this. This is a study in progress. We will be looking to 18 months post-treatment, but right now we only have 6 months post-treatment for the entire group. And so when we compare their 6 months pre-arrest rates to their 6 months post-treatment arrest rates, and this is for the full group of 41, so it's based on official records, we saw that 29% of them had been arrested in the 6 months pre, and only 12% had been arrested in the 6 months post. What we also saw was, and this is a significant reduction in the number of charges overall. This is not the charges per individual who's arrested. This is if you count all of the charges each individual has, where clearly the majority have 0. So that kind of emphasizes that difference a bit. Then when we look at some of our other outcomes, these were all with non-parametric tests because it was a small sample. When we look at the pre-treatment versus the post-treatment, pre in green, post in brown, we saw a very significant reduction in mental health symptoms. This was using the brief symptom inventory and just counting the number of symptoms that they had experience with in the previous month compared to the month before treatment started. Which, for a lot of our mental health interventions, we don't often see impact. And this is a treatment that is hand diagnostic. This is whatever the presentation is, the symptoms that they're presenting with. The therapist is trying to do the best interventions out there for it. And so we saw a significant reduction, which is very encouraging. In terms of, so I'll pop over to the other clinical outcome, substance use. We'll go into a little bit more detail in the next slide. This is their self-report. And what I want to point out is how low their self-report was at baseline and post. We've changed our approach to assessing self-reported substance abuse because there are a lot of challenges. Young people, when they first meet their interviewer, aren't necessarily going to report. They don't necessarily. We have a certificate of confidentiality that protects us as much as they can from court proceedings, so they can tell us, but they don't want to tell us. And we did a little bit of looking at we had some urine tox screens from part of the study and from their clinical records and looked at their self-report. Self-report's not a great measure. Let's just put it that way. So I'll show you the urine tox results next. But let me go to that and I'll come back to this. Sorry, get a little disorganized. We found that the majority of young people, when they were working with their therapist, actually reported a substance use issue, 84% of them. And for MST, part of doing the evidence-based practice, it's contingency management for adolescents and young adults. And part of that is doing urine tests to sort of validate your use. And at baseline, 75% of those who had some indication of having a substance use, this is from a clinical record, indicated that who had an indication that they had a substance use issue were positive in their urine screen. 6 months later, 64% had a positive urine screen, and of the same sample, then 40% at 12 months. So it's going in the right direction, but we still have 40% with substance use going on. And it's one of the toughest things that we've come to grips with in this intervention is how hard it is to reduce substance use. And primarily, it's marijuana, it's THC. And you can see down here that out of the positive screens, 21 were for THC, 3 were opiate screens for cocaine. Very, very common to be using marijuana at this age, and it's really, really hard to stop the use. So even though it's going in the right direction, so we're encouraged, we feel like that's someplace that we've got some future work to be doing. The other major outcomes that we were looking at, we looked at reducing peer delinquency, and that did also reduce significantly the number of peers that reported, the number of their peers that they reported having done criminal behavior reduced. And then we were also looking at out-of-home placements. And essentially, out-of-home could be that they were arrested or that they were in an inpatient substance use treatment. Nobody was in an inpatient mental health treatment. And those also reduced, but not significantly over time. So the outcomes are in the right direction. For a small sample, we find this encouraging. It's pre-post, so we don't have a comparison group. Typically you get to this point in your research, and what you primarily want to do is take it to a randomized control trial to really test out your outcomes versus a control kind of comparison. You may be looking at this going, well, what about those vocational educational outcomes? And that's in the next presentation when we talk in detail about the coach. But you had a question?
Yeah, for peer delinquency, could you tell if that was because the peers were actually less delinquent or because they chose different peers?
Our impression, because we didn't, in the peer delinquency measure, which comes out of the Delbert Elliott group, it's a very standardized measure in juvenile justice work. You don't ask about who it is. You probably would get a lot of answers if you asked them who was doing it. But in our analysis of their social networks, their affiliation with peers reduced across the course of this. So it probably, my guess would be that they have less affiliation with peers rather than the peers, the same peer group is actually offending less. But like I said, that's an educated guess at this point. Part of the target of the NST intervention is to reduce their affiliation with antisocial peers. So we would hope that that's why it's going down, but we don't have that directly in that measure. Other questions?
Related to that, in a younger population, the caregivers would be responsible for monitoring the pro-social versus antisocial affiliation and doing whatever they can to engage in pro-social. To what extent is that about this age group and who's doing that?
So I should tell you that all of the measures are self-reported. Other than their official corrections and juvenile justice records, all of the data are based on self-report. In part because of the variability that you get with caregivers with this age group. We couldn't reasonably identify another reliable reporter for them, although we've just put together a proposal for an R1, a big clinical trial, where we're going to try doing that by having the individual identify who knows them best at that point in time that can report for us. So it could be a moving target. So we don't have caregiver report. This is a young person reporting about their own peer involvement in antisocial behavior.
But and I understand all that, aren't they still moving in and out of family of origin?
Let's see, where do I have the data about where they're living? In the social network, I think we've got a little bit of data. The majority of these kids, when they start with us, they're living with their family, whoever their family is. The rate, I think it's about 70% of them came to us still living with their families. And about 20% of them were living on their own or with peers. And then a small slice came right into the study from having been in an out-of-home treatment setting. So these are primarily folks who are living at home with their families.
I don't want to know.
Yeah, no, go ahead.
So then, would the caregivers logically, as part of MST, taking it from a different perspective, now that you're in this becoming an adult stage of family development to this family life cycle, wouldn't the caregivers still be monitoring what they have to respond differently?
Yeah, the parental piece is really complicated for this age group. If you've got, even with a 17-year-old living at home, 17-year-old and their parents know that the leverage that their parents have in their lives is less than it was when they were 16. And for an 18-year-old, even if they're living at home, again, that leverage that parents can have is very different. The team works with parents primarily when they're working with, the primary client of this is the young person, the emerging adult. And part of what the team does, the therapists do, which I'll show you in essentially the third version of this, is to map out their social network and map out who has contributes what kinds of positive and negative things, essentially. And based on that, they then look for folks that they can help support this young person in making their choices. Sometimes that's a parent or a parental figure, sometimes it's a peer, sometimes it's what some folks refer to as an adult ally, somebody outside of the family system. So we're always looking for the social network to support a young person to make, these are tough changes. Even if you want to do other things in your life, it's hard to, this is your peer group, to break away from that. And so we're trying to leverage their social network, whatever that is, and that tends to be a moving target. Okay. All right. And just a very brief last slide to say that part of the feasibility work in developing a new intervention is that you've got to develop a fidelity measure. MST has a fidelity measure, but clearly we made some significant changes to the model by focusing on the client and by adding mental health treatment to it in a way that isn't in the original MST version. In our 5th iteration of the fidelity measure, we went through several where we asked the participants how clear it was, how well they understood it. We rearranged items. We then did some analysis to see what was correlating with one another, that we could eliminate some items. Anyway, our final version of it actually looks like we've got some variability. So this is for the 3 therapists for whom we had a good number of measures of responses. So there were 15 ratings of therapist 1, 20 of therapist 2, 18 of therapist 3. We see variability across the therapists in these different domains. So working in partnership, whoop, that was very fast. Wow. Yeah. Yeah, really. You're done.
Thank you.
There, all right. Hit the wrong button. So partnership is how well you work together in sort of agreeing on goals, that your therapist hears you, that you're doing this together in the changes. The clarity is how clear is the work that you're doing? How straightforward is the communication from your therapist to you? How well do you feel like you understand where you're going and why you're going there? The social context is how much does the therapist pull in the members of your social network into the work, and do they do it in an appropriate way? And then what we call the main things are the things that we would standardly recognize for any MST team. And so we have these different dimensions. There are additional measures for specific mental health treatments, like contingency management has its own measure that we collect data on when they've had contingency management. But we're actually feeling fairly pleased. I mean, you can't really test out a fidelity measure until you've got a bigger sample. Primarily what we see is that the possible scores are 1, having it never occur, so the baseline really for this is here. 2, the highest score is 4, the therapist always acts in that way. Yes, question?
After looking at your research to identify the particular characteristics that make for, I guess, more effective therapists and being able to talk about the partnership therapy social context, do you identify any characteristics that may have been more effective?
In working with the social context or in working in partnership?
In regards to where the therapists were and being able to communicate that information to
I'm sorry, in terms of where the therapists?
the therapists and how they communicate that information, or how they are providing information for the
Oh, okay. So in terms of, I mean, for the most part, so let me go back to say that they meet with clients daily during the initial parts, either on the phone or in person, in the initial entry into treatment. It's a very intensive mental health and antisocial behavior treatment. So that it's either in person or on the phone. There's a lot of detail in the training for the therapist. I'm not the clinical developer, so I'm not the best person to answer the question about exactly how the therapists communicate clearly, but it's a huge part of what they're doing in their clinical supervision, finding ways to say things, finding ways to hear back from the young person that they understood. And for the therapist to say too, I mean, it's again, a lot of part of motivational interviewing are ways in which you communicate that you heard from the young person what they just tried to say to you, that you feed it back to them in various ways. So that's all very much embedded in the approach that the therapists take. And all of the work that they do, I mean, they have team meetings with a clinical supervisor, primarily to make sure that they're on the model, to be sure that it's all very consistent with the MISTI model. So that's a meeting that occurs without the young person, but basically every other meeting includes the young person in the meeting. So the therapist is rarely meeting like with the parents without the client there, or with like teachers. It just doesn't make sense because they're trying to teach the young person how to advocate for themselves as well and communicate. So much of that, the young person's always there. Does that help? I'll give you, I mean, if you're really interested, you should talk with Ashley Shadow, who loves to talk about this. She's the clinical developer for it. She can give you great detail. And there is a manual that has developed out of this that has a lot of detail about exactly how to conduct this in a consistent manner that has been designed. You're welcome.
Before we leave that,
Yeah.
on the Fidelity, these are where they're audio taping or video taping those?
This is, again, a report by the clients.
Oh, okay.
So clients reporting on their therapist's behavior. So the traditional measure in MST, you can ask the therapist to rate themselves, or you can ask the family members to rate the therapist. There are two versions of the therapist appearance measure that's been revised on. We didn't, I mean, so this is the client version of it. We didn't feel like for research purposes asking the therapist to report on their own was what we were looking for.
And of the, this is more about the intervention, related to the young people in the sessions, how often were they inviting or interested in having a particular caregiver involved or someone else in the social support network? Because you're trying to build that.
Right.
To what extent is that occurring in the context of these sessions?
Of the sessions. I would say the most common individual or individuals that were involved in any kind of meeting that the therapist had with the client were the parents or people acting as parents in their lives, a parent or both parents. A lot, I wouldn't say that they're there frequently. Again, we're trying to communicate to the client that they are the focus and the guide for this treatment. And to the extent that it's an agreement together about when and under what circumstances to pull parents in. I don't have data that I can pull out for you to tell you really exactly how often. We have that data. We actually, for every session that they have, record who was in the session. But I would say, from my listening in on the consultations, I would say that probably less than half of the time do they have somebody else in sessions with them. It's primarily, it's a lot of work one-on-one with the client.
As you probably know, with the transition in response to the model, we're finding that for individuals over 18, about 95% of their sessions just include the transition facilitator and the young person and young adult. Whereas obviously for younger youth, depending on the circumstance, streetwise or not, you have very
Sure. I know one of the things that Ashley has talked about is that what really changes is if the young person's living at home or not. And if they're living at home, there's you're really wanting to help that situation work best, even if the young person is working towards getting out of living at home. And so that really changes sort of how they're working with the people who are living at home with them. But we've had young people who've had their partners, the father or mother of their child often involved. So there's that member of the social network. But this is also the focus of the third party. So let me know if you have more questions when we get to that part. Any more questions right now? All right, we will move forward. I can find it easy for you.